Welcome, 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 friends, to tonight's segment. I am so excited to have this conversation with all of you. And we have a couple esteemed panelists that I would love to interview. But before I go there, let's get into our topic for tonight, shall we? So, we are actually bringing tonight's segment from the Children's Visions Equity Alliance. And tonight we're going to have an in-touch, intimate interview with two highly esteemed doctors in their respective fields. And tonight the show is called Cataracts and Glaucoma. What should you know? Well, it turns out there is indeed a lot to know. So we're hoping that you stay tuned for the entire segment because it is so important to our community as Black people. And also, feel free to ask your questions. We love to engage you in whatever capacity we can. So do not be shy as we learn more about glaucoma and cataracts. Now, I cannot do this show on my own. Again, we have two highly esteemed doctors in our midst, and I'd like to introduce them now. Dr. Herndon and Dr. Bowden, thank you both so much for joining the discussion and for enlightening our audience tonight on glaucoma and cataracts. Now, while we're bringing them up, great, Dr. Bowden, I see you, and Dr. Herndon, I see you. And before we go into tonight's conversation, I wanted to highlight, along with being doctors in the field of ophthalmology, they actually have some really fun facts that I wanted to look into. So, first of all, with Dr. Bowden, he is an established doctor for decades experience in this particular field. But interestingly enough, he has been the ophthalmology consultant for the Jacksonville Jaguars of the NFL for the past 23 years. I think that warrants a virtual round of applause. I thought that was a very fun fact. And now we don't have only one interesting doctor in our midst. We are blessed with the opportunity to have two. Dr. Herndon has actually been named 2023's Newsweek America's Best Eye Doctors. So congratulations on making that esteemed list. I know it's not easy, and there are so many accolades to attribute to you both. So I want to just personally thank you both on behalf of Black Doctor for being with us tonight.
Thank you, Joyce.
Thank you very much.
Of course. So let's get into it. I think that the most important thing when we're talking about medical topics and how to make this information accessible, again, to our community, local, global, and beyond, is to understand the basics. Y'all deal with this all the time, and the terminology is probably quite familiar to you both. But can either or both of you just break it down really simply for us? What is a cataract?
Well, I can lead off on that. A cataract is the crystalline lens within the eye that is behind the pupil. Mm-hmm. And this lens becomes cloudy and stiff with age and other factors. This lens is normally crystal clear, and it focuses light onto the back of the eye and onto the retina. And as a cataract develops, the ability to focus at near becomes difficult, and the ability to see in the distance becomes degraded because of internal scatter of light. And all of this results in a reduction in vision, visual acuity, and quality of vision.
That sounds a little bit terrifying, but essentially you said that it's supposed to be crystal clear, but yes. What happens with cataracts is it becomes cloudy and it obstructs vision.
Correct.
So it's possible for someone to have cataracts, but not total blindness.
Correct.
Good to know.
That is right.
And not to say that he wasn't thorough, Dr. Herndon, but is there anything that you want to add to that very basic understanding of cataracts?
No, Joyce, I would say that cataracts are extremely common, and most of us will get some degree of cataract formation as we age. And so, but Frank would tell you when it might be time to consider surgery, but cataracts are just part of the aging process.
Got it. So that kind of is a little bit more comforting. It's a part of the aging process. Most of us will get it as we age. And I find comfort in that it's common, which means that there's a lot of information, perhaps, about how to live full lives, even if we've been diagnosed with cataracts specifically.
That's correct.
So let's say I do my weekly check or monthly checkups, actually annually checkup with my doctor. And my doctor tells me, I have some news for you. You have cataracts. What should a person expect to happen to their vision if they do have a cataract? I know Dr. Bowden touched on it, but Dr. Herndon, can you break this down for us? What can a person expect?
Well, we just really, in my practice, I leave it up to the patient for when it's time to have surgery. We'll try refractive, try glasses change first, but it's usually not satisfactory to patients because the problem is inside the eye. So if you're changing glasses on the outside or contact lenses on the outside, they don't really address the problem. But each of us has different needs for our vision. And so some patients may feel they're functioning okay with their cataracts. Other patients may have a lot of trouble with glare, driving at nighttime, trouble with up close reading. And so it really factors into the equation of really what the patient wants.
I love that kind of agency. I know, especially with Black people, there is a valid mistrust in the medical field. I'm curious about how you all overcome that mistrust because of historical oppression, systemic oppression, and racism. So when you get a medical diagnosis, you may not want to jump into treatment because you don't know what it means. But before we talk more about treatment, which I'd love to get to in a little bit, Dr. Bowden, can you talk a little bit more about what could happen to my vision with cataracts, or what can I expect to see? Dr. Herndon talked about blurriness, perhaps light sensitivity, but what can I expect as I'm being diagnosed?
Oftentimes, patients will also have symptoms of double vision or ghosting of vision, trouble seeing at nighttime. They may notice halos around light sources. And as that occurs, many times patients back off on those situations that give them lack of confidence with their vision. And such as they may avoid driving at nighttime. They may turn up the lights and get a little more contrast so they can see smaller print. And so these are normal aging changes, and many of us will make adjustments in our lifestyle. Now, when we are no longer able to function on our job, when we're not able to read, not able to drive at nighttime, to read the prescription, the small print on your medicine containers, then the cataracts become visually significant. And when your visual impairment is significantly impacting on your daily activities, that's when a decision has to be made. And that decision is individualized. And that's where a consultation with the eye care professional is important to help you, the patient, define when the right time is for you to proceed.
Again, I really appreciate that agency, or this idea that I can make decisions when I'm comfortable making those decisions, so long as the decisions are informed. And we've been talking about how normal this diagnosis can be with the aging process. Do either of you know how common it is with people maybe who wouldn't qualify as aging, maybe someone in their late 20s and their 30s? When should they be concerned with changes in their visions? And typically in their 20s or 30s, they're seeing an optometrist. But that, in my understanding, is different from ophthalmology. So
Yes.
when should a person who's not considered to be older be concerned about changes in their vision? And when should they consult an optometrist versus an ophthalmologist?
I would go. Well, I was just going to say, in terms of the incidence of cataracts, I would say 1 in 5 patients between 65 and 74 years of age have visually significant cataracts. More patients may have cataracts, but they're just not significantly impacting their lifestyle. When patients are over age 80, it's like 50% of the patients either have a cataract or have had surgery. When we see cataracts develop in younger patients, it may be as a result of trauma and injury to the eye, prior eye surgery, such as glaucoma surgery, corneal surgery, retinal surgery. It may be associated with uncontrolled diabetes mellitus. It may be associated with steroid treatment, either steroid eye drops, nasal sprays, and systemic medical therapy with steroids. And we even rarely see them in children, in infants. And typically those are patients that have had birth defects or may have had some injury in childhood.
Got it. And Dr. Herndon, can you speak to the difference between an optometrist or an ophthalmologist and when someone should be consulting either?
Yeah, I would simply say there are more optometrists in the country than ophthalmologists. And so I would say that also optometrists are probably the gatekeepers. I think they excel at refraction with giving glasses prescription, contact lenses prescriptions. Also, in many states, they are allowed to prescribe medications for certain eye diseases. If it comes to the point that surgery might be indicated, then that's where ophthalmology comes into the picture. But I think ophthalmologists are involved also from gatekeeping, from seeing comprehensive general ophthalmology patients to surgery. So ophthalmologists have a wide array of surgical and medical options available for us. So we ophthalmologists, Frank and I, can do medical and surgical management of any eye diseases, whereas optometrists are medical doctors who prescribe glasses and contact lenses.
Understood. So what I'm hearing is the two of you are the elite.
You said it.
All are important. It's just there are more optometrists than ophthalmologists. So you're more likely to see an optometrist annually. And maybe if things get more serious or you want different options and treatment, you will be escalated or referred to an ophthalmologist.
That's right.
Yes.
So Dr. Bounden, you mentioned glaucoma. Can we get a basic understanding of what glaucoma is and who's at risk? Is it similar to cataracts in that that's just a part of aging, or is it separate? Because I usually hear glaucoma and cataracts in tandem.
Right. Well, oftentimes they're traveling companions. Many of the patients who have cataracts oftentimes may have glaucoma concurrently. One may precede the other. Glaucoma occurs in about 2% of the population, so it's not widespread, but it's a silent thief of sight from the standpoint that most patients generally have few or no symptoms until later stages of the disorder. I liken it to a medical disorder like high blood pressure. You don't know you have it until somebody tells you have it, or until you have some dysfunction or some systemic, medical problem as a result. And the thing is with glaucoma, it does not significantly impair vision in the earliest stages. Mm-hmm. And so that's why patients who are at risk, at higher risk, should be, evaluated at an earlier stage in life, probably in their 30s or 40s. Depending on ethnic groups that they may be a part of. African American and Latinos particularly have a higher incidence of glaucoma and vision-threatening glaucoma, where disease is detected in later stages and leading to less desirable outcomes. These are patients who are in these ethnic groups need to be counseled, screened, need to be guided to appropriate evaluations to detect it in as early a stage as possible. Glaucoma, I liken it to a plumbing problem where fluid is being produced in the eye and the fluid has to get out of the eye. And if there's impairment of the outflow of fluid by a variety of causes, mechanisms, and the like, then the pressure necessarily goes up. And that pressure elevation can cause nerve damage. And that damage to the nerve can ultimately impair sight.
Interesting. And you mentioned communities that are at risk, including the Latino community and the Black and African American community. I was surprised to learn that Black people actually are 6 to 8 times more likely to have either cataracts or glaucoma. And this is a little bit off script, but can we speak to potential whys? Is it genetic predisposition in these communities? Is it diet? Is it certain physical activities that these communities are more prone to engage in, which could increase the likelihood of them being diagnosed with cataracts or glaucoma? This is for either of you, but it surprised me, especially for Black people.
Yeah, I can speak to that. So clearly with glaucoma, there's a big familial component, a genetic predisposition. If you look at a lot of work in Africa, especially West Africa that we've done, Nigeria and Ghana, the incidence of glaucoma is extremely high. And as you state, large studies here in the United States show that African Americans have a 4 to 6 times greater risk of glaucoma than their counterparts. We don't really know why, other than the familial and hereditary issues. There are really no dietary or exercise links, but we do find that patients with glaucoma who exercise do lower their eye pressure a bit. So we definitely recommend aerobic exercise 3 times a week to help keep the pressure lower. But Frank is likely right. I mean, if you don't get the pressure down, then you can still go blind from glaucoma in 2024. So it's something that we get concerned about, particularly as a family history, particularly if you're older. Then you really should get at least an annual screening visit for.
That's important to know. If you are listening and tuning in, we are talking about glaucoma and cataracts and looking at how it affects the Black community and what we can do to treat it, to better understand it. And if you have been listening and these statistics are making you nervous, you're not alone. I happen to be first generation Nigerian American. So when you mentioned West Africa and Nigeria, I said, oh my goodness, God forbid. But again, knowledge and information is power. We cannot help ourselves if we don't understand where we're coming from and what we're at risk for. So this is why it's important to have these conversations and understand that there are luminaries in the field like the ones we are speaking to today, and there are ways to work towards treatment. So you are going to want to stay tuned so you can get more information. Fear not, we are in great hands and there is hope and solutions. So we talked about cataracts and what we can expect to happen to our vision. And my understanding with glaucoma is a pressure begins to build up in your eye. But again, it doesn't necessarily mean blindness. I was reading some things about how it could kind of mean tunnel vision in the early stages. What else can a person who has been diagnosed with glaucoma expect to happen to their vision?
You want me to take that, Frank?
Well, I thank you. I would say in the early stages, they may have no awareness. As the pressure elevation in their eye is insidiously rising to, levels that are capable of causing damage to the optic nerve or interfering with the circulation to the nerve and the health of the nerve. In the early stages, the patients have no awareness. And they may have headaches, possibly. Those patients are fortunate. They then are prompted to seek an evaluation that may allow for the detection of the disorder. Typically, when the patients don't have discomfort, headaches, and visual disturbances, unless there's an abrupt rise in the pressure to serious levels. But if there's just a gradual, insidious elevation, a few millimeters of mercury, months, over years, they may have no awareness of it at all.
Let's speak to screening for those who may say, I know it's rare, but I'm experiencing headaches. I don't know what's happening with my vision, but I need to better understand what the screening process looks like to get comfortable with it. Dr. Herndon, can you speak to what screening for glaucoma looks like?
Yes, screening for glaucoma is a painless procedure. I know some of patients may be a little concerned about coming to the eye doctor, getting their pressure checked, and the eye care provider being right up close to their eyes. But rest assured, the evaluation is painless. It does require more than just checking an eye pressure. Frank mentioned how there is a link to high eye pressure in glaucoma, but many patients with glaucoma have never had a documented elevated pressure. Normal pressure is between 10 and 21 millimeters of mercury. So there's a large subgroup of patients called normal tension glaucoma who have normal pressures, but can still develop significant glaucoma damage. So if your eye care provider is just checking a pressure once a year and telling you that you're reassured, that's not right. You may need to make sure you get your eyes dilated. It's really important to look at that optic nerve. The optic nerve is a cable that attaches the eye to the brain. And over time, with the repeated insults of eye pressure that's too high for that nerve, gradually that peripheral vision closes down to tunnel vision, as you mentioned, Joyce, and ultimately to blindness if the pressure is not remedied in a reasonable fashion. And so the screening consists of checking pressures, vision. First off, we'll get a history of eye health, family history of eye diseases that you might have. We'll see what types of medications, including steroids that Frank mentioned, that might be contributing to an elevated eye pressure. And then after a full examination, we may do some testing. We may look at your visual field test. We may take a picture of the optic nerve fiber to see how much damage, how much loss there may be. So it's a very comprehensive evaluation, much more than just checking an eye pressure.
That's important to know, because whenever I have astigmatism in both my eyes, actually, whenever I go to the optometrist, I'm asked if I want to get my eyes dilated. And it wasn't until more recently that I started saying yes. And I'm so glad that you touched on this, Dr. Hurden, that it is not enough just to check, you said pressure, correct? We also want to do more comprehensive testing. And it's totally okay to ask for a referral if you want, again, more information about your eye health. What you don't know in this case can hurt you, because there are ways, again, to get on top of it, to be informed and empowered in our decision making so that we can live as full lives as possible. Anything else you want to add, Dr. Bowden, to screening for glaucoma specifically?
I would like to maybe just add that there's no one test that essentially rules in or rules out glaucoma. And in addition to the pressure, as Dr. Hernan indicated, the appearance of the nerve, their characteristic pattern appearances of the optic nerve that suggest the presence of glaucoma. And that requires an experienced eye to look at and make that assessment. And if you have an increased risk in terms of family risk, African American ethnicity, Latino, if you have a number of risk factors and a borderline pressure, then a referral to an ophthalmologist is important, a glaucoma specialist as well, to look for other more sophisticated tests that can enable a better assessment of your likelihood of having glaucoma, making the determination if you need treatment. One other test that is critically important is measuring the thickness of the cornea. African Americans have, as an ethnic group, statistically thinner corneas than other ethnic groups, and that can lead to underestimations in the true pressure in the eye. And there have been a number of patients over the years that have lost vision from glaucoma with the understanding that their pressure was in the normal range. So that's where a glaucoma specialist is critical, to have an opportunity to evaluate patients who have suspicions of glaucoma and high risk factors for glaucoma.
That's so important to know. And you may be watching thinking, well, I don't have a history of glaucoma in my family. No one in my family was diagnosed with glaucoma. Actually, you may not know. It is not uncommon for Black people to be misdiagnosed or underdiagnosed generally. I was diagnosed with an eye disease recently that I'm pretty sure my father had, and he was just never diagnosed with it. So it's also not sufficient to say, no one I know in my family has glaucoma, because it could also be the case because of our history or just access to resources where they were never given the opportunity to be diagnosed properly, or they never talked about it within the family. So stay on top of your screenings regardless, because you really never know. So we've been talking about screenings for glaucoma. Is testing or diagnosis for cataracts similar to those screenings, or is it a whole different process?
There's a lot of similarity. Essentially, a comprehensive ocular examination is required by an ophthalmologist or optometrist, and that involves a dilated examination in which a powerful microscope is used to look for cloudiness or opacities in the crystalline lens. Again, that should be crystal clear, but if there's any backscatter or any kind of reflections of light coming from that lens, that can impact the light coming inside the eye, that then gets scattered or not focused properly. It's important to look for the clarity of the cornea and look at the surface of the cornea so as to look for other causes of decreased vision that the patient may be describing. Fluctuating vision, blurred vision, ghosting of images and the like. A lot of these symptoms can arise from the abnormalities or irregularities of the surface of the eye. It's also important to have the refraction, to look for any changes in the prescription of the eye and to determine if that would improve vision, and to look for any loss of focusing ability. And then through the dilated examination, an inspection of the retina is possible to look at the optic nerve, to look at the retinal tissue, and to specifically look for any other reasons in the eye that can explain a degraded vision or loss of vision. And after all of that, then a conversation with your eye care professional determines whether or not you have a visually significant cataract that needs to be dealt with.
Now, there is a phrase that you mentioned multiple times, Dr. Bowden, and that's ghosting. I'm going to admit I'm a millennial. Ghosting means something different to us than
Oh, that's right. You're right.
It's when you're not texting them back with no warning. But I can maybe deduce that ghosting as a symptom is when an image appears and then it fades. So an image may not really be there. Or could you give us layman version of ghosting as a symptom in your eye?
I would describe it in terms of if you're looking with one eye, you see 1.5 image. You may see an edge that looks faded, and it looks like you're seeing the edge of another image that's really not there.
So it's not quite doubling. It's like 1.5.
Yes.
Oh, interesting.
And if an eyeglass correction can correct that, that may be astigmatism. And if ghosting isn't improved with an eyeglass prescription, it may be a manifestation of the cataract.
Got it. Anything you want to add to that, Dr. Hurden? Ghosting in dating, ghosting in your eyes, either?
No, I think Dr. Bowden covered that very nicely.
Excellent. Thank you so much for that clarification, because again, there are so many things that you just normalize because you don't know any better. When I was younger, I used to sit right in the front of class, and everyone thought it was because I was so eager to learn. And that's partially true, but really, I just couldn't see. I couldn't see well. I didn't want to tell my parents. I didn't want to get glasses. They were so expensive.
Yeah.
But you normalize blurred vision. And when I did get glasses, I remember looking at the back of someone's head and seeing the separate strands of their hair, whereas before it was totally a blur. So you may be listening, and there may be things that you're normalizing, like that double vision or that 1.5 vision with the blurred edges, or when you're driving at night and the lights are shining differently, or there's a halo of light. Those might not be angels. That might be issues with your vision. Again, get screened, take agency. Do not be afraid to ask for specific screenings. That is all within your right. And the more information you have, the better you'll be for it. So we already did talk about how glaucoma and cataracts are more common as you age. I want to hear a little bit more about younger people and children also getting cataracts and or glaucoma. We mentioned that it's not too common, but are there things that parents can be aware of, parents of children should be looking out for when it comes to glaucoma and or cataracts with kids?
I mean, fortunately, in the States, most schools have eye screening programs. And so any major abnormality to the eye system is going to be picked up in the screening visit, and the patient would then be referred to his or her pediatrician, and then maybe an ophthalmologist. But fortunately, cataracts and glaucoma are very rare in the younger population. But those are types of things. So there's some symptoms, for instance, for glaucoma. If a kid, a small kid or infant has large, we think about these large, beautiful eyes. But in babies, and if you have big eyes and tearing a lot, that could be an early sign of having elevated eye pressure. So that's one thing that we look for. But typically in the school process, any significant visual abnormality will be picked up.
Great. So we've talked about the background pressure. I want to thank those again who are dropping their comments. Candy, I see a question from you, and we're going to be sure to get to that towards the end. Let's move into treatment and the discussion of treatment. We've talked about how there's hope and how we should not fear. So we're going to give y'all some solutions. Doctors, what are the different glaucoma treatment options, and how would my doctor, for example, decide on the best treatment option for me?
Yeah, there are so many different options available. Typically, when I train, you would start patients on the eye drop first. If that didn't work, then maybe laser. If that didn't work, then maybe surgery. When I say it didn't work, we set a target pressure range based on the amount of damage that the patient might have. And so if the patient has mild glaucoma, then the goals could probably be in the mid-teens. Moderate glaucoma, a little bit lower. Severe glaucoma, many times we're trying to get the pressure down to under 12 or 10 or maybe high single digits, because we know that that patient is losing vision at the pressure of 13, 14, 15. And so we base our recommendations on, number one, how bad is the patient's glaucoma? Number two, is there a family history of glaucoma blindness? And number three, you have to work with the patient because they need to be compliant with their therapy. Nowadays, we typically will start a patient with a laser first. It's a laser procedure called laser trabeculoplasty. The problem with glaucoma is that the natural drain of the eye is clogged. And so lots of studies have shown that maybe going straight to a painless laser procedure first, makes a lot of sense and may put off that time until the patient might need drops or might need surgery. But there's a whole host of factors that we put into the equation when we determine which is the proper treatment for them.
What about cataracts? When should a person consider cataract surgery? And kind of in conjunction with that question, are the development of cataracts or even a diagnosis of glaucoma, are they always progressive? In that, are we always sure that this is going to become worse and our vision will always deteriorate? Or is it possible to, for example, have cataracts and it stays at a certain level for the rest of your life?
That's a multifaceted question.
I'm really good at those.
I'll start off with the cataract portion. Cataracts are progressive. However, they vary at the rate of progression. And that's why, again, it's so important to have an individualized approach to assess the patient's needs, assess their complaints, and determine how effectively they're able to compensate, cope, and deal with their impairment. There are some patients who have a low threshold and feel like any imperfection and it compromises their ability to do critical tasks that require really sharp vision. And then there are other patients in whom their world is not as active. They're not as active individually and they can live with a little blur and the like. So it's not a uniform decision that we see a cataract and, oh, it must be taken out. No. On the other hand, we basically let the patients know that they have an explanation that we can objectively see to explain some of their symptoms, and the patient, make the determination as to when it's the right time for them to address it. And similar with glaucoma, it can vary in terms of its rate of development. And so the glaucoma surgeon has to essentially assess the risk of that patient, the likelihood of that patient to progress to a point where where further damage is likely to take place. And that's requires, a detailed examination, observation, potentially observation over time, looking for progression to determine a rate of deterioration, so that we don't inadvertently create problems or expose the patients to complications and of problems that they may not have developed if we didn't intervene prematurely.
Interesting. So premature intervention can actually exacerbate or expedite that deterioration process.
Or more, expose the patient to complications. Every treatment we have has some risk, and we have to make an assessment. Do the benefits of the intervention outweigh the risks?
Interesting. That's why it's, again, so good to be informed, because a specialist is going to be able to tell you about those risks so that you can weigh your options in an informed way.
Yes.
Thank you for that. So LASIK eye surgery, especially among my peers, is pretty common. Does the existence or having had LASIK eye surgery before impact or affect refractive surgery for cataracts, or does LASIK eye surgery impact the outcomes for refractive surgery?
That's a very, very good question. In that, again, refractive surgery or corneal procedures that have been done in years past to change the shape of the cornea, the curvature, and change the prescription of the eye are prevalent. And so these are patients that are used to essentially not having to require glasses. And so when you perform a cataract operation, the curvature of the front of the eye is taken into account to determine the proper power of the lens to put inside the eye. And so patients that have had prior, we call it corneal refractive surgery, such as LASIK, RK, PRK, patients that have undergone these procedures have a higher likelihood of dissatisfaction with their vision as a result of improper lens power selection or the development of unwanted visual disturbances that that they were not expecting. And so these patients should have that comprehensive evaluation by a cataract surgeon who recognizes refractive surgical consequences on the cornea and takes those changes of the cornea into account in selecting the best lens implant to minimize unwanted vision disturbances, as well as to arrive at more precise lens power calculations. Because again, these are patients who are expecting to not have to depend on eyeglasses after their surgery, after they've enjoyed years of not having to depend on glasses.
One thing I'll take that a step further that Dr. Bowden mentioned with LASIK or having refractive corneal procedures that thin the cornea. He mentioned earlier how African Americans tend to have thinner corneas than others, and that gives an artificially low IOP or intraocular pressure. So if you have one of these refractive laser procedures or surgical procedures to the cornea, that thins the cornea further, and your pressure may be artificially lower. And again, if someone's just checking your eye pressure year after year and not doing a dilated examination, looking at the nerve, there may be a false sense of security. So I have several patients who've had LASIK years ago who come to me really advanced glaucoma because somebody who just wasn't doing a comprehensive examination on their eyes.
So let me understand this better. African Americans tend to have thinner corneas. And when we're getting these eye pressure tests, that thinner cornea can give us a false sense of comfort or not totally accurate reading, because the thinner the cornea, the difference in how the pressure is going to be read or understood. So, absent a comprehensive eye check or eye exam, that thinner cornea can throw off an optometrist, for example's reading because of the nature of their cornea, or even thinner because of LASIK.
Correct.
Yes.
That is fascinating. Again, get comprehensive exams. So I'm seeing some audience questions rolling in. My understanding is that this team is game for some questions on the fly. So let's pause right now and turn to the audience before we get back to our schedule. Candy, thank you so much for joining the conversation. And Candy would like to know if there are any recommendations on how to self-check eye pressure, maybe for those who are a little bit nervous about going to an ophthalmologist or an optometrist. Can you self-check for eye pressure? And number two, because you know I love a multifaceted question, should you, in your expert opinion, be self-checking eye pressure?
Yes, the answer is yes, that there is a device available called the eye care home tonometer system that has been validated, that is very accurate. The gold standard way of checking pressures is not the air puff, but called Goldman applanation tonometry, where we place a little small device on the cornea to flatten that cornea, and that gives us a reading. Hence, the issues with the cornea is thinner than usual. But so there is a way that's accurate, that's safe, that you can measure your pressure at home. I think that's important, because if you're getting every 6-month visit to your eye doctor, your pressure takes about 2 seconds to check. And the pressures, we know, fluctuate throughout the day. There's some evidence that the pressures are even the highest while you're sleeping. So I have several patients who have invested in this technology, and it helps us as providers and physicians to know what pressures are at different times of the day. It helps us to determine better options for our patients.
That's fascinating. It's not what I expected. I was expecting don't bother doing it at home. But what I'm also hearing from you, Dr. Herndon, is that your patients are working in conjunction with you, the expert. So they're not avoiding doctors altogether and just checking their eye pressure, but they're checking at home regularly and then reporting back to you or an expert who can help them understand their readings, help them understand the process, and help, again, formulate a plan that works for them.
Absolutely. I welcome more data points when it comes to disease like glaucoma. That can be very frustrating. The pressure may be normal when you go see your eye doctor, but it may be wildly fluctuating at different times of the day. So I definitely welcome having more information rather than less.
Excellent. So Candy, you can definitely check the pressure yourself. That is never a substitution, though, for medical advice. And that does not mean that you should not be working in tandem with your healthcare provider so that you can understand what these readings are and formulate a well-informed plan. Thank you so much for that question. Jill, thank you for your questions. One of them being, does diabetes or high blood pressure affect glaucoma? Dr. Bowden, do you want to take that one?
I would say that both of those conditions don't directly cause glaucoma, but I would say that they have there's a higher incidence of glaucoma among those groups of patients. So I use that as a risk factor to consider with other parameters that I'm reviewing to assess that patient's risk for nerve damage that may threaten their vision. So yes, it is an important medical condition that may be associated with a more severe course. There's a understanding about glaucoma that in part it has a circulatory disorder of the optic nerve that is a part of the process, and certainly patients who have microvascular disease can conceivably have a more severe outcome with glaucoma coupled with elevated pressure.
That makes sense to me. In my field, we often say correlation is not necessarily causation,
Yes.
meaning that just because there are things that are associated doesn't mean that there's a causal link or that one caused the other. So diabetes and high blood pressure, yes, affect or can affect glaucoma, but diabetes and or high blood pressure do not necessarily cause glaucoma. It's just a risk factor that your doctor is going to take into consideration if you're diagnosed in conjunction with a ton of other risk factors. So if you have diabetes or you have high blood pressure, it doesn't necessarily mean that you will have glaucoma, but definitely speak to your healthcare provider, specifically your ophthalmologist, so that we can see if there is a correlation or some kind of link there to help improve your health.
Another point with that is that some of the complications of diabetes and some of the complications of hypertension can result in glaucoma, different types of glaucoma, different mechanism of pressure elevation that indirectly damages the nerve and causes vision loss.
Okay, so complications resulting from those diagnoses, not the diagnoses themselves.
Correct.
Interesting. Let's get back to the agenda and we'll circle back to audience questions if we have time, so keep them coming. But we talked about background, we talked about treatment. I want to hear a little bit more about what happens after surgery. So what can a person do to increase their chances of success post-surgery? Dr. Herndon?
So I would say post glaucoma surgery. Let's talk about that. Maybe Dr. Bowden can speak to cataract surgery. So there are lots of different glaucoma surgeries that we perform. Again, the main goal, the only goal, is to lower the eye pressure. Because Dr. Bowden did mention maybe there's some vascular component to glaucoma, and there is. We don't really know how to treat that at this point. So we definitely can lower the pressure. There are several different surgical procedures that we might recommend. Over the past 10 years, there's a whole new class of surgeries called MIGS, MIGS, minimally invasive glaucoma surgery, that are designed to be a quicker procedure than traditional glaucoma surgery, associated with quicker visual recovery. They don't get the pressure down as low as traditional glaucoma surgery, but the outcomes for patients with mild to moderate glaucoma are pretty good in that with that category of surgery. So with those surgeries, recovery is quick. When we're traditional surgeries, it does take a time for the eye to recover. So there will be a lot of more follow-up with those more traditional surgeries.
I can speak to cataract surgery, what to expect afterwards. Well, first of all, cataract surgery involves removal of the crystal of that cataract, the cloudy lens, followed by the replacement with an artificial plastic lens implant that then restores vision. So this procedure, in the majority of cases, takes place in an outpatient surgical setting, in which it's done utilizing topical eye drop anesthesia and usually oral or IV sedation. So this is a quick procedure. It's designed for patients to be quickly mobilized within, maybe within a half an hour after the surgery to essentially go home and start using their eye drops that are designed to help reduce the risk of infection and inflammation and the like, and to lubricate the ocular surface as well. So it's a procedure in which fairly rapid visual recovery is expected. However, those patients that undergo upgraded cataract surgery, or what we refer to as refractive cataract surgery, this type of procedure is designed for early and sustained visual rehabilitation that the patient should not require glasses for the rest of their lives. And so it's a marvel to have a procedure that can involve major eye surgery in which the patient has the perception that it's a minor procedure to their eye. We have to oftentimes remind patients that they've had major eye surgery when they're seeing 20/20 or maybe a little worse the day after surgery.
So I heard, amongst many other things, an eye drop anesthesia. And I love the sound of it because that sounds numbing. So
Yes.
for glaucoma and cataract surgery, can people expect those procedures to be painful?
Well, so for glaucoma surgery, especially the MIGS procedures that I mentioned, the anesthesia is very similar to what Dr. Bowden does and I do for cataract surgery. Topical eye drops. We may give a little medication inside the eye at the beginning of the procedure. And patients may have a little pressure during the procedure. They typically are awake because many times we need them to follow direction, look left, look right. For the more traditional surgery, trabeculectomy, glaucoma tube surgery, those require some deeper anesthesia to the eye because those can be associated with a bit more discomfort.
We utilize an anesthesiologist with our surgery, and I basically tell the patients we want them in la la land, so they don't care where they are or why they're there, but they're just alert enough to be cooperative and follow directions, i.e. looking at a light overhead. That helps to keep their eyes still so that I'm not chasing them around under the microscope.
That makes sense. And that is, I'm sure, very helpful. So how does one take care of themselves post-surgery? Can they take care of themselves? Should they have someone with them?
They really should, because when we give the patients intravenous or oral sedation, it may, varying with the patient, it may take hours for the full effects of that sedative to wear off. So we certainly don't want them hopping in their car and driving back home and not have an awareness of how they got home because they're partly out of it. And so that's why a caregiver is certainly important to have when we give sedative medications like that for the first 24 hours, just to make sure that their needs are met and that they're not forced to have to hop in their car and go to the store and pick up something that they may feel that they're able to do, but it's not a good idea to do. And of course, these are patients that are typically not in pain if they're because of the drops we use, the medications we use during the surgery and after the surgery. These are designed, the powerful medications, to reduce inflammation that would be the source of the pain. And we always have patients, we always let them know that we're ready, the surgeons in our offices are readily available by phone if they have any concerns or problems after the surgery. There are rare situations where a patient may have an abrasion that may develop after the surgery that they weren't aware of, that they need just a reassurance, or in rare cases, they may need to be seen earlier than scheduled to make sure that everything is going well.
Awesome. So bring a friend, a trusted family member, get community. You're not meant to do it alone, even though you think that you can. But again, so much of what's developed and what's happening is to allow this to be pain-free. So don't be afraid if surgery is your next step for either cataracts or glaucoma. There are solutions that will help you throughout the process and help you heal and again, live a fuller life. So we have a few minutes left. I want actually both of you, to just take some time and speak directly to the viewers. What do you want them to know about preventing either glaucoma or cataracts? What can they do if prevention is possible? And again, multifaceted. So what do you want them to know? And also, what is something that you wish patients knew when it comes to education surrounding glaucoma and cataracts? So what do you want them to know in terms of prevention? And what is something that you just wish they knew in general when it comes to their own education, agency, and empowerment?
I can start, Frank, with glaucoma. So I'd like your audience to know that glaucoma does not have to be a blinding disease. It is the world's number one cause of irreversible blindness. So Dr. Bowden mentioned that it's oftentimes not associated with symptoms. So those patients who are at high risk, those who belong to the African American group or Latino group or older Americans, need to have at least an annual eye examination. Because I would like your audience to know that if you have a family member with glaucoma, your risk of developing glaucoma is up to 10 times greater than if you don't have a family history. And we've been trying to do some things on the national stage to make a concerted effort to increase public awareness around that. But also, finally, I would tell your audience that they should empower themselves and take what Dr. Balda and I have shared with you tonight and schedule an eye examination if you haven't had one in the past year. And encourage your family members also to get their eyes examined.
I would add, with regard to cataracts, first of all, they can't be prevented. It's I tell patients, if you live long enough, it's like a rite of passage. You will develop them, but it's not a situation of doom of the inevitable. Many patients live in their 70s and 80s and still function well and never have surgery. So I'd say, in terms of preventive measures, the things that you can do to halt the progression or can be simple, like if you live in Florida, as I do, you want to be mindful of excessive unprotected sun exposure. Just as you have to care for your skin and wear sunscreen and wear protective hats and the like, you want to wear ultraviolet blocking, effective sunwear when you're outside. You want to, if you're a child, a young adult, and you're engaged in, contact sports, football, basketball, tennis, things like that, wear protective eyewear. Avoid these injuries that can invariably occur, and the like. And I would say, if you have systemic medical diseases like diabetes, keep it under control. Don't allow lifestyle choices or unmanaged medical problems to allow these disorders to accelerate or develop at a premature stage that requires earlier intervention. And again, annual eye examinations when you're over 65, when you're at higher risk for glaucoma, for cataracts in particular, can at least empower you, the patient, with the knowledge that you have a cataract, and you then can make the determination when it's right for you to have something done about it.
Powerful. Get annual testing. Encourage your family members, as you heard and said, to get tested. Wear protective wear that is UV protected sunglasses, and request exams, request information. There are so many resources available to us. We have the power to change our narratives. None of this is a death sentence. So we hope that you leave here feeling informed and empowered. I want to thank you both for your expertise, for your patience, and for your time. I am very encouraged, and it's been super enlightening. So thank you for joining us tonight.
My
Thank
pleasure.
you. It was a pleasure. Thank you.
Thank you. And thank you to our viewers. Have a great night.